Hi, everyone. My name is Lakshi Aldridge, and I am the current president of the Society of Dermatology Nurse Practitioners. And I'm absolutely delighted this evening for our monthly webinar series. And it is being conducted by one of my dear friends, Veronica Richardson. She is going to be talking to us about getting to the root of it, a practical case-based approach to hair loss. Now, many of you may hear and recognize the name Veronica Richardson because she is famous for her psoriasis knowledge. And in fact, that's when I had the distinct pleasure of working with Veronica in the National Psoriasis Foundation, where she has served as a member of the Medical Advisory Board, which is quite an honor. So she has really built her career at the University of Pennsylvania, working with Dr. Gelfand and his amazing team, really focusing on psoriasis and psoriasis research. And we were absolutely delighted to learn that she also has a hair loss clinic. And so it has had the clinic for many years now. And so we were delighted that she was able to provide this lecture, because we all know that this is one of the most challenging disorders when we have a patient coming in complaining of course, at the end of their visit, by the way, I've been noticing that my hair is thinning, and everybody cringes. So without further ado, I am absolutely delighted to introduce and turn the stage over to my dear friend, Veronica Richardson. Veronica?
Thank you so much, Lakshi. I'm so grateful to be here and honored to be able to talk to you about a topic that, like many of us, kind of run for the hills when we hear hair loss at the end of that visit. But I hope by the end of today's lecture, everyone will feel a bit more comfortable approaching the patient with hair loss and deciphering what type of hair loss, and really being able to educate patients on treatment expectations and the overall management of their patients. So without further delay, we'll go ahead and get started. And just some regular housekeeping items here. Some disclosures, and then we will be talking about some off-label uses of medications, because there really are very few FDA-approved labeled indications for hair loss in our patients, which presents a management challenge. Our objectives today are that we'll review the initial approach to the adult patient presenting with female pattern hair loss, alopecia areata, and frontal fibrosing alopecia. So we know there are many other types of hair loss, but for in the interest of time, I decided to focus on the three that I see in clinic most commonly. We'll review the key clinical features as well as historical clues of each diagnosis that'll really help us nail the diagnosis and really avoid diagnostic delay, especially in our scarring alopecias. We'll review the diagnostic workup and how to interpret labs and biopsy results, and we'll also review the treatment options and management strategies. So to get started, I think many of us on the call today understand this, but just as a review, alopecia really is just a general term for hair loss. So it's non-specific. We can have non-scarring alopecias and scarring alopecias, but just saying someone has alopecia is kind of like if you ask someone what they had for dinner last night and they told you, I had meat. Okay, well, what kind of meat, right? So what kind of alopecia do our patients have? So on the left side, we have our non-scarring alopecias, and on the right, we have our scarring alopecias. And here listed again, we'll be talking about androgenetic alopecia, or I'll use the term female pattern hair loss or androgenetic alopecia interchangeably. And then alopecia areata, which is another non-scarring but inflammatory type of hair loss. And then for the scarring alopecia, we'll be discussing frontal fibrosing alopecia. The second question you want to ask yourself after you determine, okay, is this a scarring versus a non-scarring alopecia? Is this an inflammatory versus a non-inflammatory type of hair loss? So is inflammation driving the underlying process of hair loss? So that's another important key feature. So alopecia areata and frontal fibrosing alopecia, these have an inflammatory basis, versus androgenetic alopecia has a non-inflammatory basis of the hair loss. So again, important for management strategies and education. So let's get started with our first case. So I actually just saw this patient a couple weeks ago, very typical hair loss case. And today's talk is pretty timely, being on Thursday evening, because tomorrow, Friday, is my usual hair loss clinic day. So I'll be raring to go tomorrow when I see all of my hair people. So this was a patient, 25-year-old woman. She says that she's always had thin hair, but it became more noticeable over the past 3 years. So since about the age of 22. And she really thinks it's increased more so over the past 18 months. She said she sheds hair, but she doesn't think it's excessive. She just feels like whenever she sheds hair, she doesn't grow it back, which is another really common complaint that patients will say about their hair loss. She's also noticed some increased scalp visibility over the vertex and the crown. And she's also noted that her ponytail diameter has decreased in size. So that's a really common question I will ask patients is, hey, if you make a ponytail, how much smaller do you think your ponytail is now compared to, when this first started? And she said, oh, definitely 75% smaller. She's also been on combined oral contraceptive pills since 2012. Her menses are regular and were regular prior to starting her birth control. She has no unwanted facial hair growth or new acne, and no history of polycystic ovary syndrome. Notably, she recently had surgery. So she had a laminectomy with spinal fusion about 3 weeks ago. She lost 15 pounds in the post-operative period. She said her appetite was just pretty poor. She kind of was avoiding alcohol and wine, things like that. So she actually had pretty dramatic weight loss over the past 3 weeks. And then she was also told she was anemic by her surgery team. So if you see here in her labs, she preoperatively had a hemoglobin of 12.7, which dropped down to 8.7 post-operatively, and was just started on some iron supplementation by her primary care provider. Her family history is notable for her 2 brothers, aged 27 and 36, both with thinning hair. So you see here in this history, I've kind of highlighted in red some of the key historical clues and complaints that a patient may voice to you that can really help lead you down a path of what the diagnosis is. So a very common question I'll ask is the ponytail question. So why do we think her ponytail diameter is shrinking? And that's because more large hairs are being replaced by smaller hairs. So the ratio of big hairs to little hairs is skewed. And the proper term for big hairs or little hairs are terminal hairs, which are your large hairs, versus vellus hairs, which are those fine, thin hairs. So in female pattern hair loss, what happens is you are still growing hair, but the hair is growing in finer and thinner. So a normal terminal to vellus hair ratio. So if any of you have gotten back a biopsy report that you've done of the scalp for a patient with androgenetic alopecia or female pattern hair loss, you may notice that the pathologist says terminal to vellus ratio is 3.2 to 1 or 2 to 1. That means that for every 2 big hairs, there's 1 little hair. But for a normal scalp, it should be every 7 hairs or 7 big hairs to every 1 little hair. So a normal T to V ratio is about 7 to 1. Some people are higher, like 8 to 1 or 9 to 1. So the photo on the left is just a little me taking a photo through my dermatoscope of one of our nurses with a big, healthy head of hair. So you can see all of those large terminal hairs. And then the patient to the right is actually a patient who had a biopsy and her T to V ratio was 2 to 1. With the black arrow, you can kind of see that larger terminal hair. So she's still making terminal hairs, but the ratio of terminal to vellus hairs is much different. So she has a lot more vellus hairs. So if you're growing hairs, but they're growing in finer and thinner, you're going to have increased scalp visibility and the thickness of the hair is going to reduce, right? So that hair is just not taking up the same real estate as it used to. Another key feature of androgenetic alopecia, besides the increased scalp visibility, which you can see here nicely in this photo, is preservation or maintenance of the frontal hairline. So her frontal hairline is intact, but she does have some thinning over the anterior vertex and some increased scalp visibility. So again, another key clinical feature of female pattern hair loss. Going back to our patient, what did I do for her? So we saw earlier that her primary had checked a TSH, had checked a ferritin, which was normal, and then checked the CBC, which showed that hemoglobin drop. What I do in my practice is I also check a vitamin D, zinc, For her, given that she's on the younger side, so she's premenopausal and having some increased thinning of her hair, I do check testosterone as well as the DHEAS. You may be asking, well, Veronica, why did you repeat the ferritin? And what's the deal with the ESR? And the reason we do that is you probably remember back from school, and if you practice in general medicine, ferritin is an acute phase reactant, meaning that the ferritin is going to increase in the setting of inflammation, whether that be post-operative healing, whether that be recovery after a virus, whether that be the patient is actively ill while they got the lab. So I get the ESR as well as a marker of inflammation just to help me interpret the ferritin. So for example, if her ferritin came back 50 and her ESR came back 30, I'd say, wow, okay, there's some sort of inflammatory process in place. Was she sick when she got the blood work? Oh, she just had surgery. That really means that her ferritin is probably more like in the 20, 25 range versus if she had a normal ESR and her ferritin being elevated. Now I say all of this, and then you'll read that it's really on the fence whether or not ferritin is related to hair loss. So we don't think having a low ferritin makes you lose your hair, but there's some suggestion that having low ferritin or iron stores in the body can make it harder for hair to regrow and make treatments less effective. So in our institution, we do check, like I said, vitamin D, zinc, and ferritin for those reasons. And I think about it as like, let's fertilize the soil before we plant the seeds, right? Making the conditions for regrowth optimized. She's also treatment naive. So FDA approved treatment for female pattern hair loss is minoxidil. Minoxidil 5% is approved for women. They are to use it once a day versus men use it twice a day. So females once a day down the midline part and along the anterior hairline. So I'll tell patients exactly how to use it and that they're doing it in an inverted T, down the midline part across the frontal hairline. I also get baseline photos. The reason I get baseline photos are that when I bring this patient back and she says, I don't think the minoxidil is really doing anything, I can actually objectively measure from pre-minoxidil to 6 months or 12 months down the line, and we can look at those photos together. The other really important thing when you're starting patients on minoxidil is to warn them that it's very, very common during the first 4 to 6 weeks of using minoxidil to have increased shedding. If you don't tell them that and you get a call a month later stating, this minoxidil is making it worse, I'm shedding a ton, and then you say, oh yeah, that's going to happen, they're probably not going to believe you, or worse yet, they're just going to stop using the minoxidil and never come back to see you. So you really want to make sure you're counseling them on that. The other thing that in this particular case, given the scenario of the patient recently having surgery 3 weeks ago, having significant weight loss in a short period of time, is I'm going to counsel her that in 2 to 3 months, she actually may notice some increased shedding. And that's because telogen effluvium, right? So we're all familiar with telogen effluvium, where a physiologic stressor, major emotional stress, illness, childbirth can trigger more hairs to go into the telogen phase than normal and cause excessive shedding. So I'm going to give her some anticipatory guidance that, hey, just so you know, because of everything that just happened between your weight loss and your surgery and your exposure to general anesthesia, you might notice some increased shedding, but don't worry, keep moving forward, that hair is going to regrow. So I'm going to reassess her in 6 months, and then we can talk about additional treatment. So maybe in a follow-up lecture, I can let you know how she's doing. So I mentioned telogen effluvium, and I want to just briefly talk about the hair cycle and what's normal and what isn't, because again, understanding abnormal is great, but understanding normal is important too. So when patients tell you, oh, I'm shedding a ton, and then you ask them how much, and they say, like 20 hairs, that's actually normal. It's normal to shed 50 to 100 hairs every single day. At any one time in a normal scalp, about 90 to 95% of our hairs are in the anagen or in the growing phase, and about 5 to 10% are in the telogen phase or the resting phase, which is the phase in which hair sheds. In the setting of telogen effluvium, though, the percentage of hairs in the telogen phase can be 20%, 30%, upwards of 50%. And that's what really accounts for 100, 200, 300 hairs a day being shed, which is really distressing for patients, and they may think they're going to go bald, but you can reassure them that this is just an abnormal cycling. The hair cycle has to revert back to normal. The shedding will dissipate in about 2 to 3 months, and the hair will get back into primarily in the growing phase and fewer hairs in the shedding phase. So let's talk about another female pattern hair loss case. So this was a lovely patient of mine who complained of thinning over her vertex and crown that again has been gradual. So gradual is the key. It's been going on for about 9 years. She had done Rogaine 5% for about a year, and she noticed she developed some acne and some unwanted hair growth on the face. So she took a break from treatment. About a year and a half prior to seeing me, she restarted minoxidil, but went to a lower strength, the 2% spray, and was using that twice a day. So remember, 5% once a day, 2% twice a day. She noticed some improvement when she restarted the minoxidil, but she again noticed a mild increase in facial but body hair growth as well, which is a bit atypical. She was on a combined birth control pill until about a year ago, but she developed a DVT, so she had to stop that. She's also noticed some increased hair growth on the legs, in the bikini, and the face area, which has increased. She does get some coarse hairs on the chin. She hasn't had a recent lab evaluation other than a TSH that was done about a year prior to me seeing her. And she too also notes a 50 to 75% reduction in her ponytail diameter. So my plan for her was to check some labs. So again, in someone like her, she really is a potential hyperandrogen state is speaking to me. I can't tell for sure, but with this unwanted hair growth, acne, etc., I'm good in a 32-year-old, right? I'm going to want to make sure that I'm not missing a hyperandrogen state. So I'm checking a testosterone, a DHEAS. Both of those were normal. Her vitamin D was just a touch low, so we talked about repleting that. Her zinc and ferritin and ESR were also normal. From a hair loss standpoint, ferritin we usually like to see above 40. The normal range is anywhere from 15 to 150, but 40 is usually what we're shooting for. She also has a family history of balding in her father. So what I decided to do was to start spironolactone. She and I discussed spironolactone versus oral minoxidil. This patient's actually a pharmacist, so it was really nice to have that conversation with her. She understands the idea of off-label use of medication. She really understood potential side effects. And given her unwanted hair growth, we thought spironolactone was the best option for her because it could help combat, slow down some of the hirsutism as well as the acne and potentially help her hair. So baseline, we took photos. 6 months later, the only thing that had changed was that we had started spironolactone 100 milligrams daily. She was still using the minoxidil 2% spray twice a day. And this was a really nice improvement. So you can see the tightening of the midline part from the left photo to the 6-month photo here. So again, not perfect, but definite tightening of the midline part. She had noticed an improvement. She was super happy with it. Just so we all know, spironolactone, when you're using it to treat hair loss, we tend to need to use higher doses, usually 100, 150, even 200. So I had full expectation that at her 6-month follow-up, I was going to bump her spironolactone, but she was so happy with everything that she decided to stay at the 100 milligrams. So nice little spironolactone success story. All right, so this is my last female pattern hair loss case. So this is a 57-year-old woman. She presented last December. She was coming to me already with a diagnosis of female pattern hair loss or androgenetic alopecia. And I always like to ask my patients about their history in terms of shedding. How many shedding episodes have you had? Have you ever remembered a time where you shed excessively? Did you shed postpartum? Have you ever had any surgeries and shed after that? And she was very clear that in 2011, she had a ruptured appendix. She was in the hospital and she said, I was shedding for 2 to 3 months. I thought I was going to lose all of my hair. She said, I regrew, but I never regrew back to my baseline, which is a very common story with women with androgenetic alopecias. They kind of shed all of this hair and they regrow, but that kind of unmask their female pattern hair loss a little bit earlier. She estimates she regrew to about 90% of her pre-shed baseline. Then the following year, she was diagnosed with breast cancer. She had chemotherapy and lost all of her hair. And when patients lose all of their hair from chemotherapy, that's called anagen effluvium. And then she was placed on anastrozole until 2019. And she thinks during that 5-year period that she was on anastrozole, her hair loss had worsened even more so. And when I saw her, she had been off of all hormonal therapy for about 6 months. She had come to me with a biopsy that showed a T to V ratio of 2.8 to 1. So remember, a T to V ratio, normal 7 to 1. 4 to 1 is kind of borderline or suggestive of female pattern hair loss, and anything under 4 to 1 is considered diagnostic for female pattern hair loss. And she had a slightly elevated telogen count, and there was no evidence of scarring. She had started minoxidil foam once a day on her own about 1.5 years prior. She had spent a lot of money on a variety of different vitamins and supplements to no avail. Her labs were completely unremarkable. And I decided for her to start her on low-dose oral minoxidil. So oral minoxidil is being used more and more regularly for the management of androgenetic alopecia. It is used in micro doses. So blood pressure doses are 10 milligrams to 40 milligrams. Hair loss doses are going to be micro doses like 0.25 milligrams to 1.25 to 2.5 milligrams. So tiny, tiny doses. In the US, the commercially available dose is 2.5 milligrams. So I have these patients quarter the pill. So I say, buy a pill cutter, cut it into quarters. You take 1/4 of a pill. It's like licking a pill of minoxidil, tiny little bit. Continue your minoxidil foam daily. I saw her in follow-up about 3 months later, and look at the difference between baseline to March of 2021. So significant improvement, especially in the crown area and the back here. She was very, very pleased. And again, this was just 3 months. In terms of side effects, what I monitor for is obvious dizziness, lightheadedness, orthostasis, and some patients can notice some lower extremity edema or pedal edema. She had none of those. So she was tolerating that tiny dose very well. So I increased her to 1/2 pill, so 1.25 milligrams. A lot of my colleagues will start right at 1.25. I tend to practice more on the conservative side, especially since we're dealing with a non-life-threatening condition. So I'll start with the baby dose and we'll work our way up. And then after 7 months after increasing her dose, look at her nice improvement here. Again, tightening of the midline part, increased coverage over the vertex and the crown, and she actually stopped wearing her hairpiece, and I had a lot more confidence. So big change for this patient in under 1 year with the use of oral minoxidil, and tolerated quite well. So just to recap, female pattern hair loss with clinical features and historical clues, it's gradual. Patients will complain of increased scalp visibility. We will see widening of the midline part. We'll hear about a decreased ponytail diameter, and we'll see preservation of the frontal hairline. A lot of times patients will have a history of periodic excessive shedding, but not always. The histologic features, if you do wind up biopsying someone, we'll see increased miniaturized follicles, and like I said, a T to V ratio of 4 to 1 or less. And we tend to see shortening of the anagen phase, so the hair doesn't grow for as a long a period of time, and a prolongation of the telogen phase. The workup, I'll get a CBC, we'll check our micronutrients like vitamin D, zinc, and ferritin. Hormones, I'll always check a TSH, and then I'll check androgens based on the history. A lot of times in postmenopausal women, I'm not checking the androgens, but I do that more so for younger patients. And I only biopsy if I'm concerned that there's a component of a scarring alopecia in addition to their female pattern hair loss. So if I think there's something else going on as well, I will biopsy, but you do not need to biopsy female pattern hair loss. This is a clinical diagnosis, so you can make it through history and physical exam. To review the treatments, minoxidil foam is the only FDA-approved treatment for female pattern hair loss. We'll also use spironolactone, like I said, in higher doses, 100 milligrams to 200 milligrams daily, or oral minoxidil. Sometimes we'll combine the two. We'll do spironolactone and oral minoxidil. Again, I would probably not go above 2.5 milligrams for the oral minoxidil. When you get above that, you really do start to see some side effects in women, mainly increased hair growth on the face and some dizziness and lightheadedness. So sticking with the low microdoses of oral minoxidil would be the recommendation. A lot of people ask about finasteride and dutasteride, so your 5-alpha reductase inhibitors, topical finasteride along with topical minoxidil and PRP. These are all things that need additional data before we recommend them. We do not do any of those at our institution for female pattern hair loss. They have looked at finasteride in women for female pattern hair loss with not great results thus far. It's tends to be more effective in men. So I really do not use that for this indication. So moving on to this lovely 29-year-old woman, she came in with a 3-year history of alopecia areata. She said she was doing really well until about 6 to 8 months ago. She was about 6 months postpartum with her second child, and she said she started shedding. She said, you know, I figured it was the typical postpartum shedding until she started noticing bald patches. She then rapidly lost hair over a 2-week period, and then her hair loss seemed to kind of plateau. She said this is the worst it's been. She also notes some patchy and pubic and body hair loss, as well as loss of some eyebrows and eyelashes, not complete loss, just partial areas of dropout. Her past medical history is notable for seasonal allergies and atopic dermatitis. So we can see alopecia areata more commonly in those with the atopic triad. We can also see alopecia areata run in families. So I ask a family history about alopecia areata or vitiligo. So vitiligo is another associated condition, as well as thyroid disorders. So she had actually already come to me with a good bit of blood work done by her primary, which was great, which showed a normal thyroid, normal CBC. Her ferritin was on the low end from a hair standpoint. So we talked about repletion of her iron. Her vitamin D was normal, and the remainder was normal. So for someone like her with less than 50% scalp involvement, she's going to be someone that I recommend intralesional Kenalog. So intralesional Kenalog or intralesional corticosteroids, as you'll see it referred to ILC or ILK, is a pretty standard treatment for alopecia areata. Typically on the scalp, I'm going to use the 5 milligram per ml concentration. I'll also use it for the brows for the most part, unless somebody's super sensitive, and then I'll switch it over to 2.5 milligrams, just watching for atrophy anytime you're injecting in the scalp or on the face. For more highly inflammatory conditions like DLE, discoid lupus, I'll use a higher concentration, but for alopecia areata, it should be 5 milligrams per ml with a max of 20 milligrams per visit. So 5 milligrams of medication in a 1 ml syringe. You want to space the injections out about 1 centimeter apart. I'm just going to play this video while I'm chatting. You can kind of see I marked her scalp in little purple dots, so it would come up a little bit better on video. So you're just going to the deep dermis there with the injections. You're putting just 1/10 of a cc, okay, 1/10 of a milliliter of medication per dwell site. You really want to prioritize the vertex, the crown, and the parietal scalp, because those areas tend to respond better to injections. You have a higher likelihood of regrowth. So if I have someone with a lot of involvement and I'm treating them with Kenalog, and I only have 20 milligrams to give, only 4 syringes to give, I'm going to place it where I get the most bang for the buck. The ophiasis pattern tends to be the last place to regrow and the most resistant to treatment. So I tend not to waste medication there if I don't need to. I'll space the visits apart anywhere from 4 to 8 weeks, depending on how severe. And then the way I like to think about it is plant the seeds, don't bury the treasure, right? So I'll have a lot of patients who come in to see me who've been treated elsewhere, and they say, oh, you do a lot more injections than my other dermatologist did. They would just do like 1 or 2 injections in each patch, and that's it. And we find that when you space things out, you spread the medication out more evenly, you spread out the anti-inflammatory effects more evenly, and you have more even regrowth and better results. So just a little practical a piece for you to take back to your clinic. Here is another patient of mine who I saw for the first time over the summer, who's actually a fellow in our health system, and he was so excited that he was going to be able to share his wonderful regrowth. But this is a pretty typical response for single patch alopecia areata. This gentleman has had some great regrowth. I would say, if anything, he's better than expected result, because he regrew pretty quickly. So usually I will counsel patients that, hey, it may take 2 to 3 rounds of injections separated by, 4 to 6 weeks, whatnot, to start noticing improvement. He actually started noticing regrowth after the first round of injections. And remember, hair grows about a ½ inch or about 12 millimeters per month. So he's right on target. So we started in August. He had a total of 4 rounds of injections. And when I saw him just a couple of weeks ago, we didn't do injections because he was fully regrown. And I said, well, I will see you when I see you. If you develop another patch, let me know. But he did great. Another patient of mine who hasn't been doing so well, and that's primarily because of the type of alopecia areata that she has, which is in the ophiacis pattern, which means it involves the parietal wrapping around to the occipital, tends to be a more challenging type of alopecia areata. So if you see ophiacis pattern, you know you're probably in for a long haul. I would always prioritize any patches that they have on the top of the scalp and the frontal hairline first, as those are going to be the most cosmetically important in creating, a normal hairline and appearance. So I love this photo. So it's really important, again, to be able to look closely at the key features. So what you see here in this photo, and what I've zoomed in on, is you can see how in this area, if you can see my cursor, that you can actually see those open, the follicular ossia, those follicular openings there, right? It's not smooth and scarred over. So somebody may first take a look at this and say, oh, is this DLE? No, this is not DLE. It doesn't really look very inflamed, does it? It's just, she just has this oval patch of hair loss. The other thing that you notice here is she has white hairs that have been spared. Okay, so these hairs have not been attacked, and that's something you can see with alopecia areata, because the thought is, one of the theories behind the inflammation is that the melanocytes in the hair follicle are the target of the inflammation. So those are the antigens. So white hairs often get spared. And sometimes what happens is when hair regrows, it regrows white because the pigment producing cells are the last thing to come back into the area. Now, if you saw this patient, you said, I'm not really sure if I see follicular openings. Maybe she has some decreased follicular markings. If you're ever unsure, absolutely biopsy, right? If you're ever unsure, is this scarring or not, definitely biopsy. But know that in general, alopecia areata is a clinical diagnosis. So here's another patient of mine. She is 25. Her disease started when she was 15 with several small hairless patches. She was initially treated with regular ILK every 4 to 6 weeks. However, in 2018, which is when these photos are from, her disease severity really began to increase. We started her on a course of oral steroids and we continued ILK, but unfortunately she continued to flare. At the time we were enrolling in a baricitinib, which is a JAK inhibitor clinical trial. So we enrolled her in the trial. She completed the study and ultimately was deemed a non-responder, unfortunately. So this is her after she completed the trial, coming back in April of this year saying, all right, well, what do I do now? So she had just this little patch of dark hair left. So I said, well, let's try and get you tofacitinib, okay, which is another JAK inhibitor, not FDA approved for hair loss, but sometimes we can pull some strings and submit several appeals and do a peer-to-peer and get it eventually covered for the patient. So we were able to get her started on tofacitinib 5 milligrams twice a day in mid-April. And I also started intralesional Kenalog at the same time with the plans to do this every 4 weeks. So this was her in June and July. You can see some nice response. And this was her just in December. So really great. She stopped wearing her head wrap. She's got a nice little pixie cut. She's feeling more confident. This patch here, actually in the center and the photo all the way to the right, is now fully grown in. So really has made a huge, huge improvement in her. And I just want to take a minute to have us all think about, look at this timeline, right? From 2011 to 2021, from ages 15 to 25, this woman is dealing with this condition. And if you think about yourself or you think about your kids and all of the life's milestones that happen from age 15, whether it be high school, prom, graduation, looking at colleges, graduating from colleges, trying to establish yourself in your career, meeting people, intimate relationships, and think about how impactful having a disease like this can be on our patients. So really, sometimes we get so focused in the day-to-day, you have to take a step back and look and say, wow, look at this patient for 10 years has been dealing with this, and how impactful this can be, and how important it is for us to continue to look for effective treatments for this. So alopecia areata recap, clinical features: patients can have single or multiple round oval patches. I think we all know that. We'll see visible follicular openings. Patients may have a positive hair pull. So when you pull at the periphery of a patch, you're getting multiple hairs coming out. Patients could have exclamation point hairs, which is often a feature of active disease, and they may even have some nail dystrophy. They can have pitting, they can have trachonychia, which is sandpaper nails. Histologically, under the microscope, in acute alopecia areata, there's going to be a lot of inflammation around the bulb of the hair follicle. They'll often refer to it as swarm of bees. Patients will have, there will be melanin incontinence. You can see some miniaturization as well. And then you can see inflammatory cells in kind of the empty space where the follicle was. In chronic disease, you don't see that inflammation, but you see most of the follicles in telogen and a lot of miniaturization. So the timing of when you biopsy will kind of determine what you see under the microscope. So what do I do when I work up these patients? I definitely get a TSH. We know that there can be an association with thyroid disease and alopecia areata. Again, identify if there are any deficiencies like low vitamin D, ferritin, or zinc. I'll check a CBC as well. I'll check a transglutaminase antibody only if I'm getting a review of systems that is leading me towards celiac disease. There can be some association between those two, but that's pretty rare. Maybe in all the hair patients that I see, maybe I check that twice a year in terms of in the 2 patients a year. Additional baseline labs, obviously, if you're thinking about starting systemic therapy or any immunosuppressive therapy, just like any other dermatologic disease. So for treatment, mild disease, typically less than 50% scalp involvement, we'll be doing intralesional kenalogs. Most experts agree 5 milligrams concentration is the way to go. And then for moderate to severe disease, it's really, we have a lot of options because there's not one that's perfect. The JAK inhibitors, I think by far are the most hopeful, but currently we don't have any FDA approved. So keeping our fingers crossed for that. Systemic prednisone. You can also do topical immunotherapy with either DPCP or squaric acid. Some use cyclosporin for a limited period of time. I've used PUVA before. I've used methotrexate. So again, anytime you see kind of a long host of treatments, it's usually because there's not one silver bullet for every patient. So we really have to understand that going into this. I will just briefly make you aware that recently in the JAD, the ACE study was published, which was essentially the alopecia areata consensus of experts study. So 50 hair loss gurus from around the world were surveyed about their treatment of patients with alopecia areata of varying severities and kind of what they recommend or what consensus they have come to. The general takeaways is that the lab evaluation is patient dependent. So I will tell you that they did not, the consensus did not say you have to check a vitamin D, an ESR, zinc, ferritin, etc. That's just what I do in my institution. So it's always important to make that little disclaimer. And then what the first line treatment is for adults. So they basically broke it down by SALT score, which is the severity of alopecia tool score. So under 30% scalp involvement, 31 to 50% scalp involvement, or greater than 50%. And you guys can take a look at that. And I put the reference down there for your review as well. So when do we biopsy the scalp? So, there's a misconception, and I think patients, a lot of times will come to me and say, well, I need a scalp biopsy, don't I? Well, no, you don't. So you biopsy if you think there's a scarring process at play. Or let's say in alopecia areata, if you're treating a single patch and it's completely resistant to treatment. So that should raise a red flag that maybe this isn't alopecia areata. And then depending on what you're looking for determines where you biopsy. So if you have someone with really, really advanced androgenetic alopecia, or female pattern hair loss. And let's just say they're like, I don't believe it. I need it in writing. I want a biopsy. I want to know exactly. Well, you would actually biopsy on the vertex versus in alopecia areata, you're going to biopsy on the edge of an area of loss, so the edge of a balding patch. And in scarring alopecia, you're also going to biopsy on the edge of an area of scarring and active inflammation. So over these next few slides, I want to show you kind of the patient, where I biopsied, and then what their subsequent biopsy showed. So this is a patient with androgenetic alopecia. And the reason I biopsied her is because she actually had a lot of reduced follicular marking. So I was concerned that maybe there was a potential scarring process at play in addition to her female pattern hair loss, but thankfully it was not. But you can see here with this biopsy, I did it on the right vertex. So again, with female pattern hair loss, you want to biopsy on the top of the scalp. So on the vertex, not on the side, not on the occiput. And that's because the distribution of terminal hairs to vellus hairs and the hairs that are going to be most likely to miniaturize are in this area, and you'll get a proper ratio, or the pathologist will get a proper sample so they can do an accurate ratio. You will see a normal number of hair follicles, which is anywhere from 20 to 30 or above. You see here that, again, she has that T to V ratio that is less than 4 to 1, which is consistent with prominent follicular miniaturization, and there was no scarring seen on her biopsy. So this is a patient with discoid lupus. So again, kind of this rip-roaring, inflamed, hairless plaque that had been going on her scalp for over 10 years. She had never shown anyone before. So again, I'm going to biopsy on the edge of an inflammatory area. So if I were to biopsy in this white area, this kind of white burnt out, I would not see any inflammatory cells, and it would be very hard to characterize the inflammation and actually get a diagnosis. So making sure you're biopsying in the correct place is incredibly important. This patient, so this is tricky, right? So you may think, well, I don't really see what's wrong with her hairline. Well, she had actually noticed that her frontal hairline was thinning and starting to recede. So she's very, very in tune. She's a physician, and she's like, I know something's up. My eyebrows are thinning, my hairline is thinning. I'm wondering if I have frontal fibrosing alopecia. And I said, well, I think it's quite possible. Let's do a biopsy within an area of loss that also still has some hair, that has some perifollicular scale and erythema. So you want to direct your biopsy towards an inflamed area where there has been some loss, so you can see kind of that balance between scarring and inflammation. You'll notice it further down in the biopsy report, it says the histologic differential would be lichen planopilaris. Well, lichen planopilaris and frontal fibrosing alopecia look exactly the same under the microscope. We differentiate them based on clinical appearance. So loss of eyebrows and frontal hairline recession is frontal fibrosing alopecia, versus lichen planopilaris is going to have a different look to it with more patchy scarred loss throughout the scalp. And then finally, alopecia areata, what does that look like under the microscope? So I highlighted here 30 intact follicles. So the follicles are there and they're ready to grow. The way I explain it to the patient is inflammation has attacked the hair follicle and has kind of put it into hibernation mode. And we need to use whatever we can to reduce the inflammation to allow those hair follicles to come out of hibernation and start growing a hair again. The important thing, if you're biopsying someone, for example, like this with alopecia universalis, if you were doing that, you would want to make sure you biopsy in an area that wouldn't be susceptible to follicular miniaturization, like due to androgenetic alopecia. So you want to go off of the vertex, like to the right or to the left, or even the occipital scalp. All right, so moving on to our last few cases. This is a 53-year-old woman who came to me with a 5-year history of significant eyebrow loss and frontal and temporal hairline thinning and recession. She was initially treated with intralesional Kenalog, clobetasol solution, and minocycline. She couldn't tolerate the minocycline due to some nausea. She had persistent, so she stopped that. She had persistent inflammation and hairline recession despite the topicals and the intralesional Kenalog. So I started her on Plaquenil back in 2015. She's actually doing pretty well and had pretty good disease control for a couple of years from 2015 to 2017. Then in 2017, she actually developed this new area of inflammation on the crown of her scalp, which is atypical for pure frontal fibrosing alopecia. But this is where that overlap between frontal fibrosing alopecia and LPP can happen. So I urge you to, in their patients who have frontal fibrosing alopecia, don't just focus on the frontal hairline when you're examining them. Do always make it a point to check throughout their scalp, because she's actually one of about 5 patients that I have who has developed this pattern of inflammation elsewhere in the scalp. And if you catch it really early, you can get it to regrow. And chances are you are going to catch it early, because we're seeing these patients pretty regularly. So when she had that increased inflammation, despite being on Plaquenil topicals and intralesional steroids, I said, you know, why don't we add on to therapy? And at that point, more and more people were using finasteride. So I added finasteride 2.5 milligrams. About a year later, she started noticing some gray facial pigmentation changes, right? We know drugs like minocycline and Plaquenil can cause that. So I said, hey, why don't we stop the Plaquenil? Your disease progressed despite being on the Plaquenil. You're doing really well now on the finasteride. Let's take the Plaquenil off so we can help with that pigmentation. So we stopped that, continued the finasteride and topicals and intralesional Kenalog every 8 weeks. The pandemic happened. So from December of 2019 to June of 2020, she actually had no intralesional Kenalog, because we had shut down to that. We were not doing injections in the setting of the height of the COVID pandemic. And she actually had stable measurements when she came back, which we were both really pleased with. It was kind of this forced break from injections to see, well, how well is this finasteride and topicals holding you? And she actually was holding really well, which was nice. So I continued her on the finasteride, and right now she actually moved out to California, but she comes back every 6 months to get her injections and visit family, and she's doing really, really well. This is her close up. So again, from a distance to the untrained eye, you might not notice much of anything, but really do listen to your patients. If they're like, my hairline is creeping back and my eyebrows are going away. So if you look really closely here, you see a lot of follicular dropout. Okay, doesn't look very inflamed here. She's got this lonely hair right here, which we'll do a zoom in of another patient with some lonely hairs, which is another diagnostic clue of frontal fibrosing alopecia. And then if you look, her eyebrows, she had them microbladed. So from a distance, it looks like she has brows, but when you look close, she's just got a few sparse hairs. So eyebrow loss, frontal hairline recession. Here's another patient of mine. She's a 72-year-old woman who came to me with pretty advanced frontal fibrosing alopecia. Another clinical feature that you can see in these patients is forehead vein prominence. So she had not had any intralesional Kenalog. She was not using topical steroids. So this is not atrophy related to steroids. This is atrophy related to the fibrotic nature of the disease and some loss of sub-Q underneath. So patients get prominent forehead veins here and here. The other thing that you can see here is look at the line where her photo damage begins and ends. So her old hairline is actually way back here. Hopefully you can see my little pointer, but her hairline used to be here. So she's had significant band-like recession of the anterior hairline. She too had this pattern where she developed loss on the crown of the scalp. So I saw her at her usual visit and I took a look through her scalp. I said, oh. And then a few months later, after doing injections, we were able to get that back. So we were able to rescue those hairs that were being attacked by the inflammation to prevent them from fully scarring over and having permanent loss. So that's the importance of making sure you're really looking throughout the scalp and staying on top of these scarring alopecias. Some other clinical features that we can see with FFA, if you've read about FFA, you may have read about FFA with facial papules. And the idea is that there's involvement in vellus hairs as well as terminal hairs. So the vellus hairs on her face, there's inflammation there. And you can see on her right temple here, she has this kind of papular appearance. And again, this was all new with her eyebrow thinning and her hairline recession. You can see more closely here, perifollicular erythema, so redness right around the hair follicles. Many times you can also see a little scale right around the hair follicle that almost looks like I call it like a little turtleneck of scale right around the hair follicle. And she too has some lonely hairs. So what are lonely hairs? Lonely hairs are these hairs just sitting out in the middle of scarred areas. For whatever reason, the inflammation did not attack these hairs and they're sitting out there lonely. But this is a really a classic feature of frontal fibrosing alopecia. And again, you can see that frontal hairline recession, some prominent forehead veins there. And you can see how it can really be very impactful on the overall appearance for the patient. Also, you will read about frontal fibrosing alopecia involving the occipital scalp. So this patient also has frontal hairline involvement, but pick up the back of the hair too and look on the posterior, the occipital hairline as well. It absolutely can wrap around. So make sure you're checking that area and you treat that area just the same. In terms of kind of just a quick little recap, band-like recession of the frontal hairline, it's got to start somewhere. So a lot of times patients will notice thinning of the hairline first and then recession, eyebrow loss. You'll see lonely hairs, forehead vein prominence, perifollicular scaling, perifollicular erythema, sometimes even papules or pustules. Itching may be absent. You know, I have some patients who said it's the worst itch I've ever felt. It's constant. It's crazy. And I have some patients say I haven't felt a thing in my scalp. So, of course, it's helpful if the patient does have symptoms to kind of monitor their response to treatment by, tracking how itchy they are. But many of my patients say, I just noticed the change. I've never felt anything abnormal in the scalp. Histologically, you'll see a lymphocyte predominant inflammatory infiltrate and scarring. For the workup, it's really patient dependent. I'll always check a TSH in them. There has been some discussion in the literature about thyroid autoantibodies and frontal fibrosing alopecia or lichen planopilaris. So I do check that. And then I will biopsy. You really should be biopsying your scarring alopecias just to confirm the diagnosis. And it can give you a sense of how active the inflammation is as well. In terms of treatments, topicals, whether they be topical steroids or topical calcineurin inhibitors. I will tell you kind of what I do in a couple of slides. We also, of course, do intralesional steroids. I will tell you that with frontal fibrosing alopecia, because of that baseline atrophy that they develop, I usually will be more likely to use a very tiny amount of 5 milligrams per ml or 2.5 milligrams per ml concentration of Kenalog, just to avoid worsening the atrophy. But systemic agents range from 5-alpha reductase inhibitors, Plaquenil, tetracycline class antibiotics, and then systemic agents like acitretin, methotrexate, Cellcept, pioglitazone has been used as well, and then some physical modalities like excimer laser. I unfortunately have not been able to get excimer covered for patients, so I haven't done that. I've had a patient try PRP. Again, PRP is kind of that treatment that's looking for a condition. So I don't recommend that at this point. It's quite expensive. I would think of it as a last resort. Dr. Shapiro published a nice little guideline here for medical therapy of frontal fibrosing alopecia based on whether it's rapidly progressive or slowly progressive and how much hairline recession they have. So I left the reference down there for you to review on your own. I would say by and large, the top 3 medications that I'm using are going to be Plaquenil, Doxy, and finasteride. Everyone that I see, unless they have completely burnt out disease by the time I see them, gets intralesional Kenalog and topicals. And when I say topicals, I mean dual therapy with a high potency topical steroid like clobetasol, and then a non-steroidal anti-inflammatory like tacrolimus, but we have it compounded in Cetaphil lotion. So they're not kind of rubbing ointment into their hair, which nobody really likes rubbing ointment into their hairline. I can't say that Cetaphil lotion is perfect, but it's better than rubbing ointment into the scalp. A lot of compounding pharmacies are now also making solutions. I will say I'm a little bit hesitant to use solutions right now, only because there's some concern about the solutions doing a better job penetrating the skin and then you having detectable levels of TAC in the bloodstream, which we don't want. You really do want to watch for atrophy around the hairline, as I mentioned, and then objective measurements. So, right, not just relying on the patient saying, oh, I think my hairline's going a little bit back on this side, or my front is receding more. Patients are not as great of historians as we wish they could be. So taking objective measurements, so the measurements that are published when they do studies on frontal fibrosing alopecia in terms of disease severity and ongoing monitoring is measuring the from each lateral canthus to the new hairline. So right lateral canthus to new hairline, left lateral canthus to new hairline, and then glabella to new hairline. So those are the three measurements that I take. I usually take measurements every 3 to 6 months, depending on the tempo of their disease. And I take photos of those, and you can see right there, those are the photos that I take. And I'll actually use that and sit side by side with the patient and say, okay, actually, I think the right side is looking good. You're pretty stable. And that's great, because some patients really need to see that in order to feel good about kind of how their treatment is going. If they're progressing despite topicals and ILK, I'll add a systemic agent. I used to use a lot of Plaquenil and Doxy, and more as of late, I've been using more finasteride. We tend to use finasteride more so than dutasteride just because it's a shorter half-life. Remember, if you're using finasteride in a premenopausal woman, it can cause birth defects. So you really want to be very, very careful with that. And most will avoid using that in premenopausal women. So in summary, it's very important for us to be able to identify the hair loss patient first as whether or not they have a scarring alopecia versus a non-scarring alopecia. With female pattern hair loss, it's non-inflammatory and non-scarring, but there's a lot of miniaturization. With alopecia areata, it's non-scarring, but it's inflammatory, and think hibernation mode. With frontal fibrosing alopecia, it's inflammatory and it's scarring. And once the hair is gone, it can be gone for good. So you really want to be aggressive about it. If there's a concern for scarring, the biopsy should be a 4mm punch biopsy in an area of inflammation. Intralesional injections, the location varies based on the disease you're treating, right? So in alopecia areata, I'm injecting into the bald patch, versus in frontal fibrosing alopecia, I'm not injecting into that scarred over band-like recession, right? I'm not going to inject into scar tissue. I'm going to inject to preserve hair where it is. The lack of strong data and randomized controlled trial and guidelines for treatment recommendations of hair loss disorders is really something that we need to work on together to really help our alopecia patients more effectively. And then educating our patients on their type of hair loss, what kind of treatments work for their hair loss. So I'll have patients who come in with androgenetic alopecia and say, I want those steroids injections in my scalp. Well, that's not going to work. And this is why it isn't. So giving patients the knowledge to better understand their disease, I think overall makes them happier. And making sure that although our patients will often bring up hair loss at the end of the visit, making sure you give them the time that they need. So if I'm seeing a patient and at the end of their visit, they say they want to talk about hair loss, my common response is, listen, I have a whole clinic dedicated to hair loss, because it really takes some time and consideration and a thorough history and evaluation in order for me to be able to treat you in the best way possible. So why don't we make a separate visit and dedicate it to your hair loss? And patients really appreciate that and hear that, because I think a lot of times they're brushed off as being told, oh, it's just related to aging. It's fine. It's fine. But you really want to make sure that you're getting a thorough history and taking the time needed. So with that, I will end and we can go into questions.
Veronica, that was truly the best hair lecture I have ever heard. It was absolutely phenomenal. And we have a ton of questions, so I don't want to take up time. So the first question that we have is, why are for the minoxidil, why is the men dosed BID and the women are dosed Q day? Always thought it was because of styling. Does BID work for women better?
So you can use BID for women. The trouble with BID for women is it tends to have more unwanted hair growth on the face. So that's the main reason that they're using it once a day. And the clinical trials were shown to show improvement with just once a day use. So I will have some women who come in using twice a day, but I tell them to go down to just once a day. I don't think it's any more effective.
Got it. This was an important question by me. Kidding. What about Nutrafol? Commercials sound like there's clinical improvement, and Megan commented mixed reviews and very cost prohibitive. So any comments about Nutrafol?
Oh, yes. So my 57-year-old patient that I presented had tried Nutrafol, I think Viviscal, biotin, all of those things. So my collaborator, who I learned everything I know about hair loss, says you're just making expensive urine. So we really only want to replete what you're deficient in. And really it's vitamin D, ferritin, and zinc that have the data behind it, or limited data behind it, I should say. So I deter patients from using it. I said, save your money on that, treat yourself to something different, but you don't need to buy those expensive vitamins.
Can you talk about oral minoxidil, which you did? When is the best time to use it, and what do you counsel your patients about side effects?
Sure. So the best time, there's no hard and fast rule. I will never jump to that first. I will tell you that. I will always have patients start with topical minoxidil. Okay. If they have an allergic reaction to topical minoxidil, or they get, a lot of scalp irritation, just an irritant dermatitis, then I'll consider going to oral minoxidil. Other situations where I'll consider going to oral minoxidil is if someone's been on topical for a year and they're still very unhappy with where they are, then I'll have the discussion about spironolactone versus oral minoxidil. So those are the common situations where I'll use it. I would not use it in older patients. I will say in patients over 65, I tend not to contribute to polypharmacy, especially older patients where we're worried about dropping their systolic blood pressure, who could be very sensitive to even tiny doses. I tend not to use it there. And then in terms of side effects, so I often will refer to Dr. Rodney Sinclair's publication in 2018 or 2019, where he used low-dose minoxidil combined with low-dose spironolactone in 100 women. And 4 women developed urticaria, so hives. One woman, I believe, developed unwanted hair growth on the face, and a handful of women developed lower extremity edema. So that's kind of what I base my side effect discussion on. In real life, I have not had any women complaining of bothersome unwanted facial hair growth. So luckily for us, dermaplaning and shaving the faces is very big for women these days. So a lot of women will say, I'll notice a little bit of fuzz, but honestly, it's doing such a good job for my scalp. I'm okay with, doing that. And I have seen pedal edema in one patient, and we stopped it, it resolved, and that was it. So it's pretty safe in those tiny doses.
Okay. And how long do you talk up to patients about how long they will need to be on minoxidil? Some patients seem to be hesitant because of the length of time. And you didn't mention checking any potassium at higher doses used for hair loss. Do you worry about that at all? I think also for spironolactone.
Got it. So for minoxidil topically, I think you were referring to in terms of how long they need to use it for in general. Yeah. So that, patients say, well, I don't want to use it forever. I say, well, this is a forever process, right? And usually when you ask them about it, it's because they say, well, I'm going to lose all my hair when I stop it. So this is what we talk to patients about is, yes, minoxidil only works while you're taking it. However, when you stop it, you will lose whatever gains you had on the minoxidil, but you will not be worse off than you were before having started it. So you'll never have a net loss of hair. You'll lose the progress that you made, but you'll go back to where you would have been if you hadn't used the minoxidil. So that's what I explain to patients. In terms of checking potassium, so if in healthy women without kidney disease who are not on a drug that can cause hyperkalemia, like an ACE inhibitor, I don't routinely check potassium levels. If I have a woman over the age of 45 and I'm starting spironolactone, I will check a baseline lab just to make sure they don't have any underlying renal insufficiency that I didn't know about or nobody knew about. And then if they're fine, I don't routinely follow-up potassium levels on spironolactone. And that holds true for acne as well. And those are the, the recommendations that are out there, that we don't actually need to check regular potassiums.
Is there a max number of times you would do ILK? If a patient continues to have a good response, how long would you continue for?
So there's a type of alopecia areata that as one patch regrows, another patch develops. So you feel like you're constantly chasing patches. I continue to do intralesional Kenalog for as long as the patient wants to do it and they still have active patches. So I have some patients with that type of alopecia who I've been seeing for the entire 10 years that I've been in practice. Now they don't come every month, they maybe come every 8 weeks, but you can do that indefinitely, with the exception of if you're injecting the same patch over and over for 6 months and there's been no improvement, you should stop. Okay, that's saying you're injecting the same exact patch. Or if someone's developing such significant atrophy, I would give them a break from the injections. Especially, we have a lot of male patients, for example, who've lost all the hair on their scalp and they just want their eyebrows to give them a normal look. Those are the patients you worry about developing a lot of atrophy because you're injecting on the face. So those are going to be patients that you have to really play it visit by visit to make sure you're not causing more damage.
Perfect. Can you give us a quick and dirty explanation of how you guide your patients through squaric acid treatment?
Yeah, no, that's a great question. So there are a few different protocols out there, but the first step is to sensitize someone to the squaric acid. So you actually can do that either on the inner arm, or you can do it on the actual scalp in like a 4 centimeter by 4 centimeter area. So you do a higher strength there to sensitize them. A week later, you reapply a lower concentration to the same area, and you want to reapply it weekly and elicit an inflammatory reaction, okay, or a contact dermatitis, essentially. You want to counsel patients that they should leave it on the scalp for 48 hours before washing it off, and they should not let it be exposed to sunlight. Those are kind of the main key points with the squaric acid treatment. There's some discussion about squaric acid not causing as much of an inflammatory response as DPCP, but still very effective at regrowing hair. What I really like is in the Bologna text, there's a nice little a little table of how to do contact immunotherapy, and that's what I would refer to. It's one of those things, if you don't do it a lot, you constantly have to refer back to the protocol, but there's one in Bologna, and then there's also published, I think I have, let me just see here. I think I have, and I can send out the reference of what I use. I had put it in my notes here. Yeah, you start with a 2% solution to sensitize them, and then you go to a lower percentage, like 0.01%. And again, 48 hours after application, they can wash it off. But if you have additional questions about that, I would, again, just seek out your references.
Do you get pushback from insurance companies regarding coding for hair loss visits and treatments, including ILK?
So I did a while back, I'd say like 5 to 7 years ago, I had trouble with it. And then I just submitted letters saying that this is not a cosmetic issue, because that's usually their one-liners, that this is a cosmetic issue. I said, this is an autoimmune condition of the hair follicles with significant negative effects on patients' quality of life and day-to-day functioning. And I have not had a problem, turning those appeals around. I'm running into the same issue with getting JAK inhibitors, approved as well. They'll say, oh, this is cosmetic. But I think if you really, when you write your letters or you do your peer-to-peer, honing in on the auto-inflammatory, autoimmune nature of the condition.
Do you find the cost of compounding the clobetasol, tacrolimus, and Cetaphil, is that very expensive? Is that a barrier?
So I don't do them all together. So I do clobetasol on its own, and then the tacrolimus and Cetaphil, yes, for some patients it can be. So our compounding pharmacy charges about $70 for a 3-month supply. I would say most of my patients are able to swing it because I'm not having them use it every single day. I'm having them use it in combination. So they may be using it just 3 times a week. So they'll get at least a 3-month supply out, at least 3 months worth from the supply that they get. So usually kind of cost per month is doable for them. But if it's not, I will just have them use tacrolimus ointment. It'll be a little bit messier, but we'll do the same thing.
Got it. And at my institution, it is common practice to use ILK 10 mg per mil for all inflammatory hair loss. What are your thoughts on that?
So if you look at, so I think it's a bit much. So I think you really run the risk of causing atrophy. So you would really want to be careful with that. There's no evidence to support that 10 milligrams is better than 5. And if you look at the ACE, the consensus panel, 5 milligrams is the preferred dose. And this is, consensus that was reached by the experts. So I would consider going down to 5. Like I said, the scenarios where I will use 10 are going to be conditions like discoid lupus, or folliculitis decalvans, where it's so inflammatory and patients have boggy scalps and a lot of inflammation. That's where I'll consider using 10.
Great. Do you recommend checking TSH when a patient is off biotin?
Yes. Yep. Great question. Yes. So check biotin can impact the TSH and give you an altered read. And I honestly can't remember if it's falsely elevated or falsely lowered, but you do want to have them take a 1-week break from their biotin. The other thing I have them do is if I'm checking a ferritin and they're taking a multivitamin that has iron, I have them take a week off of their iron supplementation or multivitamin that has iron before checking that.
Amy asked, you mentioned initial hair loss with topical minoxidil. What is the reasoning behind that? I think that you covered it, but any further comments? I just want to make sure that we're hitting everybody's question.
Sorry, say that again, Lakshmi. I'm sorry.
So for initial hair loss, I'm treating it with topical minoxidil. It's pretty standard for really anything, correct?
Correct. Yeah. So for androgenetic alopecia, female pattern hair loss, that's kind of really the first line. You'll see that topical minoxidil can be added in with frontal fibrosing alopecia treatments, with alopecia areata treatments, but it's not the primary. It doesn't address the primary issue of inflammatory scalp conditions, right? When they use minoxidil for scarring alopecias or inflammatory alopecias, it's really just, I think of it as like fertilizer, right? So you're increasing the anagen phase of the hair, so it's growing for a longer period of time. So I tell patients that if you want to use minoxidil on top, that's fine. But a lot of times patients are just done with putting so many things in their hair. So I really try and reserve it just for androgenetic alopecia, where I say, we know this is doing what it needs to do by halting that follicular miniaturization, keeping the hair growing for a longer period of time, and getting as many hairs that are in that telogen phase back into the anagen phase.
Great. What is your opinion? I think you talked a little bit about that, about PRP for female pattern, and what is the recommended protocol? I think that you covered that.
Yeah, so I will say we don't do PRP at our institution. I know it's been looked at in female pattern hair loss, and as well as frontal fibrosing alopecia and LPP. And I think the jury is still out in terms of how effective it is and what type of hair loss it's best for. I really can't speak to that because I don't use it, so I don't know what protocols are used. I do tend to consider it like a last resort. Again, it's quite cost prohibitive, so most people don't have, $500 to $1,000 to try this. So I'll always try and try things that have more evidence behind them.
Great. And Karen LeMay, hi Karen, for patients coming in for injections, are you billing just for the injections or for an office visit as well? If so, are you getting rejections or any issues with that?
Yeah, so my patients who I bring back every 4 to 8 weeks, it's a procedure only visit. Yeah, we did have issues. You cannot bill an E&M if it's purely they're just coming in for their alopecia areata follow-up. Their initial evaluation Or if I'm adding a systemic agent and there's some evaluation and management and some risk there, I will bill an office visit. But by and large, my injection patients are procedure only.
I love Dev's next question. Collagen supplementation also seems to be popular for patients to try for hair disorders. I haven't seen anything compelling, any compelling data to support it, or is it just another example of making expensive urine?
Yeah, it is. I think, again, no, there's no data to support it. And that you have to remember, and I'm sure out of the almost 200 people who are listening today, some of us are dealing with hair loss ourselves, and you're willing to try anything. So I think, unfortunately, people kind of prey upon that. And if patients think there's hope and they hear, oh, it's clinically proven, well, what clinical trials are really behind it? They'll try it. So I, again, really try to encourage my patients to avoid those things and really try and do everything based on what the evidence shows so far.
Wonderful. Veronica, this was just an amazing lecture. And for all of you who had the honor and pleasure of hearing Veronica today and liked what you heard, please join us in April to see and meet Veronica in real life at our annual symposium. It is going to be live in Nashville, Tennessee, April 22nd and 23rd. We hope that you will join us. We just have a great lineup of speakers, including Veronica, because gosh knows that hair disorders are just always such a challenge, no matter how long you've been in the field. So we were really looking forward to having you join us. Next slide, please. And then for those of you who have not taken that next step to become certified, that is a goal and mission of all of us here at SDNP, is to help do everything we can to support dermatology nurse practitioners to become certified. We are having a live review course immediately following the symposium in Nashville on April 24th and 25th. We have a stellar faculty that will be providing complete and thorough overviews to help you be prepared for that meeting, with Peggy Vernon as the chair of that program. So please go online at www.dermnp.org for any further information. And again, Veronica, thank you so much for taking the time this evening and sharing your knowledge and expertise. Your patients are so incredibly lucky to have you. And gosh, I was the patient who comes back from California every 6 months to see you. What a testament to your expertise and patient skills. I'm just so honored that you're an NP. So thank you so much for sharing your expertise with us tonight.
It was really my pleasure. And I hope that everybody on the call really, you can manage these hair patients. It takes, it's, in some ways it's complex, but in a lot of ways it's quite easy. And I think what we're really good at as nurse practitioners is educating our patients. And that's a big piece to this. So I hopefully this gives you some confidence to be able to kind of really attack the patient with the hair loss concern and really be able to think about it in a systematic way. So I was so honored to give this talk and really, really appreciate it and hope people found it helpful.
Thank you so much, Veronica. Thanks everybody for joining us. Unfortunately, we need to leave the call, but if you like what you heard, please join us in Nashville and bring your friends and we'll get ready to have a great time. Good night, everyone.